Past history of neck irradiation. Okay, past history of neck irradiation. Okay, it's very, very important. Drug therapy, previous some of drug therapies like lithium, like amiodarone. If I have women over 35 years of age, elderly patients, pregnant women during the first trimester. If I have women 6 weeks, 6 months, up to 6 months after postpartum period, or I have elevated levels. These are populations at risk which requires more attention for thyroid disease. When I have to measure total thyroxine, okay, if I have to measure total thyroid hormone, which is free and protein bound. I know you know that thyroid hormones, just small part of thyroid hormones are free and large part are bound to proteins in the blood. So I have usually T4 hormone combination with TSH for measurement of thyroid function. This is the main measurement of thyroid function. It's combination of TSH and T4 hormone. What's the conditions in which the thyroxine increase? Thyroxine increase if I have hyperthyroidism, like enlargement of thyroid gland, increase of the function of the thyroid gland, and what we have factitious hyperthyroidism. In some cases, if I take the hormone from outside, I take thyroxine drugs. This is called factitious hyperthyroidism. If I have pituitary TSH secreting adenoma or secreting tumor from the pituitary, the increase of TSH will increase the secretion of T3 and T4 hormone. If I have raised thyroid binding globulins, so will increase the total thyroxine. Vice versa, in decrease of the thyroxine in case of hypothyroidism, decrease of the function of the hypothyroid. If I have pituitary hypothyroidism, this is a secondary condition. Why called secondary? Because the decrease of the thyroxine hormone secretion from the thyroid gland is because due to decrease in the secretion from the TSH from the pituitary. So if I have pituitary hypofunction, I will have decrease in the secretion of TSH, and in turn this will decrease the T3 and T4 hormone. In some cases of Can you hear me now?
Yes.
Okay.
Yes.
So these are the conditions in which I have decrease in the thyroid hormone, maybe from the hypothyroidism due to decrease in the function of the thyroid gland, or decrease of the function of the pituitary gland, so decrease in the TSH, and if I have severe non-thyroidal illness, and in a case of decrease of thyroid binding globulin. Free T4, this is a very, very small fraction of total T4 which is unbound or not bound to protein binding globulin. So I have total T4, this means I free T4 and the part of T4 bound to the binding globulin in the plasma, and the free part of the T4, it's a small fraction of the T4 which is not bound to. This is the metabolically active form. This is the metabolically active form, the important form of T4. This cannot be affected by thyroid binding globulin levels because it's not bound to protein. In which conditions the thyroid binding globulin will increase or decrease, and so will affect the total T4 and T3. It can increase, thyroid binding globulin can increase in the following conditions, maybe like some drugs like estrogens, oral contraceptive pills, very, very important. I have some genetic causes, causes of increase of the thyroid binding globulin, in some cases acute and chronic hepatitis, during pregnancy, acute intermittent porphyria, okay, angioneuritic edema, and hyperproteinemia. The vice versa, in case of decrease of the total binding or thyroid binding globulin, in case of androgens and glucocorticoids, okay, and large doses of acetyl salicylic acid. This will decrease the total binding globulin, and so will decrease the total. This will decrease thyroid binding globulin, so decrease the total T4 or total thyroxine hormone. In case of malnutrition, and so hypoproteinemia, other causes of hypoproteinemia, like and also in nephrotic syndrome, acromegaly, Cushing syndrome due to the increase in the glucocorticoids, liver cell failure, and in case of sepsis. These are causes of decrease in the thyroid binding globulin. Also T3, I have free part and total part, and the free part of T3, again, it's the active form of T3. And the bound to protein, it is the larger one or much one, and the non-active one. So the more active, metabolically active T3 is the free T3. When I want to assess the thyroid function, first I want to estimate the serum TSH. Okay, it's the most important number to just to know that normal TSH is up to 5 international units per liter. Okay. Also, I have to assess thyrotropin releasing hormone, okay, by TRH stimulation test. How can I perform TRH stimulation test or thyroid releasing hormone stimulation test? First, I have to measure the TSH. Then I will give the patient thyroid releasing hormone intravenous. Then I estimate the TSH again after 20, after 60 minutes. Normally, I have, when I give the patient TRH, normally the TSH will be increased, as you know, from the hypothalamo-pituitary thyroid axis. Normally the TSH will increase by increase the dose of TRH. But if I have no raise in TSH, this is a case of thyrotoxicosis. This is a case of thyrotoxicosis. So in thyrotoxicosis, TRH stimulation test will cause no raise in TSH. Also, when I want to assess the thyroid function, don't forget assessment again of T3, T4, free and total T3, free T3 and free T4, total T3 and total T4, TSH, TRH stimulation test. And the fourth one is radionucleotides study. Okay, here I use radioactive material, whatever, iodine or technetium. Here I will use radioactive material, which can be metabolized by the thyroid gland, and I can assess the degree of the function of the thyroid gland from the uptake from the thyroid gland. I have some examples of radioactive materials I can use for assessment of thyroid function, like iodine 123, technetium 99, iodine 131, and radioactive iodine 125. Here I have half-life of each one. The half-life is very, very important. Why? Because I will assess the gland during this period. I will assess the gland within this period. So usually if I want rapid assessment, okay, I can use some radioactive nucleotides or radioactive materials within short half-life, like iodine 123, in which the half-life about 13 hours. Technetium, the widely used now is technetium, which can be half-life 6 hours. Okay, but I have iodine 131 and radioactive iodine 125 about 60 days. Usually I use this for assessment of thrombosis because this is the life of RBCs, not used in the thyroid. And also iodine 131, which in this half-life about 8 days. Okay, so usually we use the first two ones, iodine 123, radioactive iodine 123, and technetium 99, because of shorter half-life. So I have iodine 123 uptake test or technetium uptake test. If I use 123 iodine or technetium, I use this for assessment. Here I give the patient orally the iodine, but the technetium is given intravenous. I give orally